Good. So good afternoon, everyone. My name is Joy Kemp, and I'm the Global Professional Advisor at the Royal College of Midwives UK. We are the Professional Midwives Association in the UK, and we've had a twinning project with the Uganda Private Midwives Association since 2012. Mary, can you introduce yourself?
I'm Mary Musoke. I'm a practicing midwife in a rural setting maternity center, and I'm the president, Uganda Private Midwives Association.
Wonderful. So we're going to talk to you this afternoon about a twinning project, a health partnership which exists between the Uganda Private Midwives Association and the Royal College of Midwives. And we have implemented two projects together since 2012. We've had 26 UK midwives who've gone to Uganda as volunteers, and they have undertaken 27 placements in midwifery regulation with the regulatory body, the Uganda Nurses and Midwives Council, with Midwives Association, with different education institutions, and also in many different practice sites. Sorry, I might continue with the presentation. In the last 5 years, we've had 3 exchange visits to the UK. We've also had 12 workshops, and we've had a visit to Prague together. Mary, do you want to take us through the rest of this slide?
Okay.
We can hear
We
you now.
had a visit to Malawi together to see if we have possibilities to bring on board the Malawian midwives, and 11 Royal College midwives staff plus consultants visited us. We also had a visit and you stay with our twins both in Uganda and the UK. Then we had the co-presentations and conferences. This we have done it several times. And we did some research, although it was new, to see how we can prove that mentorship can work. And this one is still in progress. We are hoping to do a co-publication as well.
Great. Grace, I'm seeing that you're having some technical problems. Are you able to hear us?
I can't hear her.
No, her microphone is muted, but shall we continue? Should you give us a thumbs up if we should continue?
I'm back on now. We were trying to get it louder, but it's fine.
Okay, great. Okay, great. So from between 2012 and 2015, the Royal College of Midwives was lucky enough to receive a grant for just over £500,000 for a global midwifery twinning project. This was funded by UK Aid through THET, and it was for 3 countries, Uganda, Cambodia, and Nepal. And the purpose of that was to strengthen the professional midwives associations in each of those countries. Twinning is a concept that comes from the International Confederation of Midwives, and they promote twinning between member associations to strengthen each other. And at the end of the project in each of those 3 countries, we undertook a needs analysis. And so I'm going to move on to the next slide and ask Mary to tell us how mentorship was identified as a need.
Yeah, at the end of the first project we did with the RCM, when during the evaluation process, we contacted several stakeholders, but we identified the lack of mentorship for students in clinical sites. But at the same time, we were also employing some of the newly qualified midwives, and as private midwives, we had already identified this gap. So in December 2014, A successful pilot mentorship project was run between UPMA and Chibuli School of Nursing and Midwifery. And the students here, they gave us a surprise when they told us that ever since they've been mentored, this was the first time when it was hands-on purely. For example, monitoring a mother from admission up to discharge, and then you follow her up in her house, rather.
That's great. So that pilot project was really well evaluated, and the students said that they had never experienced such a good quality of mentorship before in any of their placements. And that gave us the confidence to develop a new mentorship program for Uganda. So, Mary, could you talk us through the slide? Introduce us to Mercy, whose picture is on the screen, and tell us about the involvement of the Nurses and Midwives Council.
Okay, before is Mercy Mwanja. She's the Quality Assurance Manager, Uganda Nurses and Midwives Council. But when we realized that this was very important for us as midwives, we can't work alone. It was very, very important to involve the council because it is the governing body. So we had to work hand in hand to see that this one is officially recognized in our country. And Mercy was really very impressed when she told us that they had issues with the nurses, not only with the midwives, but they had issues with the nurses and the midwives being produced in trainings, but they didn't know what was wrong and how to put it right. So she went on saying we had a belief that if we trained our mentors, they would be able to bring out quality nurses and midwives required to serve the people of Uganda. So they welcomed the momentum idea.
So it's always been really important for us to involve the Ministry of Health and to involve the Nursing and Midwifery Council and to ensure that our programs align with the government strategy for maternal and newborn health in Uganda. So we want to tell you a bit about Momentum. This is the project that we're presenting this afternoon. Momentum stands for developing a model, that's the MO, of mentorship for Ugandan midwifery, so Momentum. And this was an action research project, and it ran between 2015 and finished this year in April 2017. Momentum was designed as an action research project because action research by its nature is participatory. And it was really important for us that if we were to develop a model of mentorship for Ugandan midwifery, then it had to be truly participatory and it had to fit completely with the context of midwifery in Uganda. So it was designed around 3 cycles of action research involving all of the actors that have a part to play in midwifery mentorship, right from the very top to the Ministry of Health, down to the individual students and also the beneficiaries. So that was our project. And Mary, we move on to the next slide. Tell us about how we planned for sustainability right from the very beginning of the project.
Yeah, this was very important for us. And how we did it is to involve everybody. Wanted everybody to come on board. And this we included our stakeholders. Of course, we had to start with the Ministry of Health and the Nurses and Midwives Council and the other stakeholders like the schools. So everybody was brought on board to look at how are we going to sustain this in our own country. So it is very important when you are looking at sustainability plan, you have to involve the partnership.
Thank you. And you can see in these pictures the Commissioner for Nursing and Midwifery from the Ministry of Health at the top, and also the
The minister, she's now the Minister of Health.
yeah.
The one
So
standing next to me.
yeah, she has a yellow and brown dress on in the top left-hand picture. She's now the Minister for Health, and she herself has been a midwife, and we're really delighted that she's been fully on board with this project. And so at every stage in all of the activities that we undertook, including developing the project plan and developing the M&E framework, and you can see these bits of paper over the wall in the picture, it's been truly participatory with everybody involved. And that takes time. It's not a quick way to run a project, but we believe it's a sustainable way. And we follow that proverb that if you want to go fast, go alone. But if you want to go far, then you should go together. But that takes time. So I'm just trying to move on to the next slide. Here we go. So I'll talk us through the part of this slide and hand over to Mary for the right-hand side. So the goal of this project was that amongst the targeted student midwives, there would be an improvement in knowledge, skills and attitudes. We found that knowledge, skills and attitudes was a phrase that's very familiar within Ugandan midwifery and had meaning. So that was the goal that they wanted to set. And then the outcomes, we knew that in order for this model to be sustainable, we had to involve the Nursing and Midwifery Council, and there needed to be a national standard that we were trying to attain with mentorship. So one of the outcomes was to increase the capacity of the Nursing and Midwifery Council to develop a mentorship standard. And then we also wanted the targeted midwives who would be trained as mentors to show an improvement in knowledge, skills and attitudes around mentorship. And the third outcome was that there were 4 clinical pilot sites, and we chose them to be representative in some way of the provision of midwifery care in Uganda. So there were 2 government health centres, a cohort of private midwives clinics, and then also a faith-based mission hospital. And we wanted to see improved clinical learning environment at all 4 of those pilot sites.
So we had also to look at our outputs, and one of them was to draft a standard module for mentorship. This one we achieved it, and we were looking at, well, this was a new area, the work-based learning approach and the CPD module. It was new, but it is now insisting. And we had targeted 84 students mentored, but there are more compared to the number we thought. We had 4 mentors trained and 4 clinical pilot sites improved.
Thank you, Mary. So those were the goals and the outcomes and the outputs that we wanted to achieve. So what did we actually do? Well, there were a number of project interventions. You can see on the left a lovely picture of 7 UK midwives. So because this is a twinning project, it was both a twinning of organizations, but also a twinning of individual midwives. And so we selected 7 senior experienced UK midwives to twin with a Ugandan counterpart. And that should be someone who was in a similar position and with whom they could share expertise. So for example, we twinned the quality and standards, quality assurance manager at the Ugandan Nurses and Midwives Council with a UK midwife, Liz, who had many years experience of working in standard development at the UK Nursing and Midwifery Council. We paired midwife teachers with midwife teachers, and we paired midwives who were responsible for organising mentorship in the clinical learning environment in the UK with similar counterparts in Uganda. Those twins undertook 2 placements, each of 4 weeks, one in year 1 and one in year 2, but also each twin couple was provided with a smartphone, a simple smartphone, and they were able to maintain virtual contact and support throughout the length of the program. We set a standard for them to communicate at least once per month, but in fact most of the twins communicated at least once per week, and many of them more than that. And indeed they're still in touch with each other, and there is a project WhatsApp group which, although the project has finished, is still very much active. So we had those UK midwives as an intervention. We also had 5 visits from RCM staff. We had 6 workshops, as we said, 3 cycles of action research. And we were lucky to have input from a Manchester University program called the Change Exchange, which helped us to understand better the change that we were trying, the behavior change that we were trying to elicit, and to think about how we could design our interventions to achieve the most behavior change.
Yeah, it is also very important to look at the partnership goals, and here it was mainly the communication strategies. So we said you have to meet quarterly. The management has to meet quarterly. That is the one in UK and us in Uganda. And the UPMA monitoring and evaluation officer is regularly visiting these sites, both private and government, and she gives support whenever necessary.
Thank you, Mary. When you collect data, you need data collection tools, and what we tried very much to do was to identify tools that were already existing in Uganda or had been validated in another similar project. We've also done some work on mentorship in Nigeria, and we were able to adapt some of the tools from there. Wherever possible, we used tools that were existing, and I won't go through them all, but I want to draw particular highlight to the reflective grids. Reflection is a skill, is a concept which is quite new within nursing and midwifery in Uganda. And it was very successful in this project. We developed some extremely simple reflective grids where mentors and students could map their learning and reflect on how they were going to use that learning in practice. Mary, would you like to say something more about that?
Yeah, this one, the reflective grid didn't help only students or mentors, but it also helped us because most of the time we get new staff on board, and this reflective grid was just helping us to do the same to the newly qualified, although this was something for the students, and that's why we are also eager to see if we can move from students to the newly qualified staff.
Thank you.
Yeah.
So this is a diagram of the mentorship model that we developed during the Momentum project. You can see here in the middle of the diagram that there is a triangle, and this is the mentorship triangle. Wherever students are mentored, there are 3 actors: the student, the mentor, but also the clinical learning environment. You can have a student, but are they ready to learn? Is the mentor capable and available to train the student? And then does the clinical learning environment support that learning? So for example, if a student needs to learn how to take a blood pressure, is there a blood pressure machine available? If a student needs to learn to maintain good infection control standards, is there running water? Are there appropriate buckets and cleaning equipment for infection control? So if you just train a mentor without addressing the learning environment and without addressing the needs of the students, then the mentorship, the learning doesn't take place. So we needed to address each 3 of these areas of the triangle and develop the necessary teaching and assessment tools to be able to capture that learning. So that's the center of the diagram. And then in the next layer, the mentors need to be trained. And so one of the work streams in this project was to develop a module to train midwives as mentors. And it was important to us that that was a work-based learning module. We did not want to take midwives where there are already so few midwives and remove them from their clinics and health centres to train them as midwives. And we believed that mentorship was essentially not difficult and that every midwife, given the right support, could learn to be a mentor. And so one of our UK volunteers is currently undertaking her PhD in work-based learning, and that gave us a wonderful wealth of expertise to draw from. So we developed a module and we tested every element of that module during the workshops to ensure that it was acceptable within Ugandan midwifery and also reflected the reality of the clinical learning environment on the ground and was related to the standard that was being developed. And because this was action research, we wanted each of these aspects to be developed concurrently and then to be tested during the workshops. And of course, where you have students, the schools of midwifery have to be ready to send and support the students in the clinical learning environments. And that was indeed a challenge, because we found when we went to the clinical placement sites that students in one site might come from many schools. And so we had to extend our reach and involve many more schools. And in fact, we ended up mentoring 141 students from 8 different schools. And there was a lot of work in engaging each of the teachers and the principals within those schools to ensure their willing participation in the project. So Mary, do you want to just talk us through the last circle?
The last circle is also as important as the inner and the outer, but to do this, we need a wider stakeholders being involved in research, because you can't do it alone. You can't be the teachers and say, as teachers, we are going to do this, or as midwives mentors, you need to have a wider range of stakeholders. Also, it's very important for effective sustainability. You need to supply equipment in the clinical sites, because, you know, these midwives need a lot of hands-on. If she has never used any equipment, it will be a big challenge. Or even sometimes they see it for the first time when they are posted, when they didn't have chance to see this in the clinical sites. And we were looking also at the workforce, because as you know, midwives in Uganda, we are very busy. You can deliver 10 midwives, mothers, but I'm wondering how you can be able to get time to mentor. So this one, we wanted to work on the ratio, and working on decreasing this ratio of mentor to mentee. We tried to train more midwives in mentorship.
Great, thank you, Mary. So we've explained to you our goals and what we did and the model that was developed. What were the results? Well, we set out to mentor 84 students. We managed to mentor 141, which was wonderful, and each one of those demonstrated improvements in knowledge, skills, and attitudes. We did indeed train 40 mentors. The national mentorship standard was developed. It's now in its second draft and is in process of being adopted and rolled out. We developed the module and the various resources such as the reflective grids that go along with that. And the clinical environments were improved in 7 clinics and health centres. And also for us, an unexpected result was the engagement, the deeper engagement with our UK midwife members, with us as a professional association as a result of being engaged with this project.
Yeah, when we look at the sustainability part of it, the Ugandan Nurses and Midwives Council adopted the standards and the module. because they realized that we can't come up with a module before we look at the standards. And this was very good because it was not only for the midwives, but they realized that even the nurses needed this. The Minister of Health was prompted to start mentorship project, not only for the midwives, as I say, but even the doctors and every cadre, so long as you are in school. Then the partnership with UPMA stakeholders was really improved. We now have a very wide range of stakeholders working with the Uganda Private, maybe because of the exposure and of so many reasons. Anyway, mainly it was exposure, because some of the partners didn't know much about UPMA, but when we came up to train with the Royal College of Midwives, this was something we really achieved as an association. And then we realized they were sharing, as the RCM volunteers realized that after coming to Africa and seeing how our members were being involved, because for us we are meeting monthly, then they said for us to take so long without going for these monthly meetings, and they thought it is high time they are also fully involved, more involved in their association. We were very happy to hear that from them.
Mary, do you want?
Yeah, we were so much impressed. For example, when we were doing the evaluation, one of the students said to us that I was mentored by Sister Christine. This is a midwife from public setting. And she said, I've learned many new skills and I feel more confident because now I can deliver mother independently. This was student Grace. Then one of the midwives, senior midwives from Wachuso Health Center 4, she told us that at first when we went, everybody said that is her case. Everybody was shying away that the students are wasting their time because they have a heavy workload. Then they they couldn't believe that they could get time to mentor, to talk even to these students. But when we went back, she was telling us that all the 5 midwives at Wachuso Health Center have been trained as mentors, and you have mentored 14 students. With Kade was one of the consultants who was trained with this health center, and she said that we have upgraded our health center, our staff have changed their attitude, our deliveries have increased, and we have so far fewer referrals for sepsis, because at first when we had just gone there, when we looked at their data, they were referring so many babies and said high temperature, high temperature. So we were surprised when we went back. She was sharing with us, this Robina, that they are now have fewer referrals for sepsis. Of course, that high temperature must have been connected with infection control. And the CADE had worked so much in this area, improved the washing, even sent in some equipment from where she was working, and she did. You see the uniform, even what Robina is putting on. They used to put on their blouses and skirts, and then from home they go back with this one. From home they come back with the same blouses. So you see, some of the uniforms they were offered by CADE.
Great. Thank you, Mary. So, of course, we had some challenges. There are always challenges.
Yeah. When you have achievements, challenges are there for us to learn. Here, the biggest challenge was communication. For example, some of our friends are now lost. I can't even see them. Helen, I can't see her. Grace, I can't.
I think they're there. They've just turned off their cameras. I think they're still there.
So we have communication, the time difference. You want to talk to her, and then she tells you that I'm deep in the bed sleeping. The availability and quality of internet also, especially with us, that is also another challenge. Lack of smartphones, not everybody has a smartphone, and the workload on both sides, because even the UK midwives are overloaded with work. The same applies to the midwives from Uganda. And the workload pressures for midwives, as you know, and the wider partners, e.g. the council, they are having very few staff. Moreover, they have a lot of work. Sometimes you want to talk to Mercy, but you can be told that she's really very, very busy. She has gone to attend this. She's now up country, things of that nature. And of course, you can't avoid the sickness. And when you already used it to a certain person, you hear that she was transferred. And that one was also another challenge, because we had our mentors in certain areas. When we went back, they said, sorry, she was transferred, but all the same, those were challenges. And this was a very short project, took us only 20 months. And of course, we were full. We were challenged when we were given the new concepts of action research, where we didn't know. We were wondering, what is this? Until they said this research, you do, you review, and you apply. Moreover, you had been doing such things, but this was a new concept. Even the worker-based learning concept was also new to us. And everybody had different expectations. The Ugandan midwives had different expectations. Then even the UK, everybody was wondering, what am I going to get? What are the benefits of this project? But in the long run, I think everybody has realized the importance of our project.
Thank you, Mary. So just very briefly, because I think we're running out of time, let me run through this slide. We picked out just a few key strategies of success with our twinning. We said it's really important to set the direction of your projects, to develop your projects, and to make all of the decisions together. And as we've said, that takes time, but it's sustainable. There has to be transparency and trust between the partners. And that also takes time, and it's a multi-layered approach. And we've been through some highs and some lows, but there is certainly some transparency and trust between the two partners. Communicate, communicate, communicate. And you have to really work at communication, even though UPMA office, for example, has internet. Even this morning, it took us around 1 hour eventually to connect by Skype. And we each have to seize every opportunity on both sides when we see it. Mary, do you want to just tell us very briefly, please,
Yes,
what have been some of the organizational benefits for UPMA in being a twin?
I had a great understanding of the 3 pillars. And one time I was even requested to go and present about the pillars when we were celebrating the Midwifery Day. There was also a lot of engagement with the Minister of Health and other stakeholders. We were proud to see that we had a national model of mentorship, including the standard and in the module. We strengthened our engagement and lobbying and the advocacy skills. We also strengthened our organizational capacity, not only with the midwives, but even the staff. And we strengthened the research, as you've had, skills and practice, improvement in 18 clinical sites, including UPM and Ministry of Health plus faith-based units. We also improved in the clinical skills, like the delivering mothers in different positions and managing some of the obstetric emergencies, and the mentorship in practice really now at UPMA. and we are promising to mentor more schools.
Great. And as we said earlier, the benefits are not just one way. In the UK here, our Nursing and Midwifery Council currently has a plan to axe mentorship, to get rid of the concept of mentorship and to bring in an alternative way of supporting students. And we're deeply concerned about that. And so having evidence from Uganda about the impact of mentorship really helps us to make a case for mentorship here in the UK. So it's impacting UK midwifery as well. We've already spoken about the engagement of our members, which deepens when they're involved with our projects. And it's enabled us to really develop those senior midwives, both professionally and personally. We've done a survey capturing their experience, and every one of them has highlighted a great deal of development during their involvement in the project. At the RCM, we now have a global strategy, a global framework, and a global team, which we didn't have before. So this work has enabled us to grow our team here, and it's spawned new health partnerships for us. So, for example, we now have a new project in Bangladesh, which is funded also by DFID through UNFPA. And the work, we were approached to do that because of the work, the track record that we've had with midwifery societies in other countries. We've also had an opportunity to participate in research and publications and presentations, and our own staff have been developed. We've been able to build in some staff development to these twinning projects. So that's the end of our presentation. Thank you very much for listening, and I think there may be a few moments for questions. At the question time. Can our hosts facilitate the question time, or would you like me to facilitate that?
Anybody got any questions?
No.
Questions?
I just wanted
Okay, Mary and Joy.
Yes.
There's a question for one of the students. Come here. Can you come through? Sorry, our video has been muted by the host.
That's fine. We can hear you clearly.
Okay. So this is Angela, one of the students who's got a question.
So my question goes to Madame Maria.
Yes, please.
You said you're offering mentorship in the schools and the facilities. Now, I wanted to know what is the difference between the training institutions, the trainings that are provided in institutions and the mentorship. What difference have you created?
Now, I think you're looking at our experience here in Uganda. Now, if I take you to Mulago, you can see how the hospital is congested. And what we had found out that even the newly qualified midwives who are working with us, they were not able to carry out a delivery on their own. And some of them shared with us that they had never delivered a mother on their own, that it was the first time. Because when we are mentoring this, in our private health facilities, we have few students and we have enough time. We don't have so many mothers. We can really help a student to hand a mother from the time of admission until delivery and discharge. But in Mulago, you can admit your mother, but delivered by another person. Or you can be called as a student when they see that this one is full, when you've not gone through the monitoring of this mother. That's why we are also trying in these health centers, we are trying to see that we reduce on the number of students to the mentee, to the mentor. So that is the difference, maybe, if I can explain. I don't know whether I got right your question.
Yes, that is it. Now, I also wanted to know, now that we've trained so many students and they are out there in the field to practice.
Yes.
What strategies are you going to make sure that you're going to meet their needs in terms of service delivery? Because they are the ones going to serve their communities.
Yeah, because we did this when they were still at school. We had to follow them up. And we are planning, even if we go beyond, not only for a short period, but we want to follow them up. And maybe that will be another area of research. If a student has been mentored by a private midwife and another one was mentored in a hospital where there is a lot of, is there a difference between these two students? But we try to follow them up and see, but we have not been able to follow, because when they finished school, they were posted somewhere. But when they are with us, we also try to take them through some business management, and we are trying to see that they have an idea of entrepreneurship when they qualify. Whoever is interested, because each student has her own interest. Another one wants to become a professor, another one wants to become a manager, things of that nature.
Thank you.
Thanks, Mary.
Thank you, Angela. Any other questions from anyone else?
I'm just going to turn you around to the students. Anybody got any questions? Oh, they're all waving.
Hello, nice to see you all. Oh, what a lovely wave.
Do you have a question? Come, you don't, you're just waving.
I don't have a question. Nice.
Oh. Oh, that's great. Did you hear that, you two?
No, can you repeat it for us?
So one of the students was one of your mentors, and she was so inspired. She's come back to do a bachelor's here.
Oh wow! Who is she? What's her name?
Come on, stand up and shout. Christine.
Christine, where were you working before?
Christine, I was working in the center. I'm still mentoring.
Can you hear Joy?
No, where did she say?
Hang on, come down to the front. Come here. Isn't that amazing?
That's fantastic.
Yeah, these are our brand new students.
Oh, wonderful.
They're upskilling to bachelors.
Ah.
Hello, Joy.
Hello, Christine. How are you?
I'm okay. Yes, I'm very happy to hear my student appreciating me, although I'm also a student now. And in fact, I went back to upgrade because I wanted to teach them the more. And I'm so happy to hear them appreciating.
Oh,
that's great. So you were working at Makono previously?
Yes.
Wow, and that was the example we used, and there you are in the flesh. That's fantastic.
That's amazing.
We hope you are doing a lot of mentorship.
That's great feedback.
What a coincidence.
Yeah, and that's really exciting to hear that that's encouraged one midwife to take her own education further. So we're really delighted to hear that.
Oh, great story.
Yeah, great. Any other questions from maybe, I can see there's a few other people still on the line. Does anyone else have any questions for us? No? Okay. Well, just to say that I'm looking forward to coming to Uganda on the 26th of November.
Okay.
And I'll be there for around 2 weeks. So I'm hoping that anyone who would like to meet us while you're there, we'll be having another workshop focused this time on dissemination of the findings from the project. So if anyone would like to join us, especially Professor Grace, you'd be very welcome.
I'd be delighted to be there. Thank you.
Great. And anyone else who wants more information, do get in touch with us. And it's been wonderful to have this opportunity to present to you all this afternoon.
Oh, thanks, Joy.
Thank you.
Thanks, Mary.
Yeah, I'm requesting you to promote twinning because you have benefited a lot from twinning.
Yeah. Okay, all wave bye-bye. Wave bye-bye. Bye. And again, give it a big wave, got the full screen. Yay!